Hello, everyone. Welcome to my podcast series, Said on Air. Today is our fourth episode of the series. For those who are new to this series, I would like to introduce myself briefly. I am Dr. Said Ahmed, a certified pediatrician and clinical researcher from Australia. I'm also a passionate food health advocate. Today, we have a very special guest, a well respected colleague, one of my idols in diabetic food research, and a friend. He has so many hats. Professor Jaap van Netten, who is a human movement scientist and an internationally recognized expert in biomechanics, human behavior change in diabetic food care. I'm very honored to welcome Professor Jaap van Netten in this podcast series. Yep, good morning from Sydney and good evening from the Netherlands. Thank you for making the time to join us in this podcast. I know you have a very busy schedule and especially making the time to join us in Friday evening after all the hard work you do in the clinic and also in the busy family life. Thank you and welcome to this podcast series.
Thanks so much, Sayed. And thanks so much, and really good to be part of this great series.
Good, thank you. And so now we can move on to our main discussion points. I know everyone is really keen to hear about the real clinical experience, life experience from Professor Jaap van Netten. So we can start with our first discussion point. I know it's your favorite area also, and you have been doing this for a long time, which is biomechanics and behavior in diabetic food care. Your work heavily focuses on interplay between biomechanics and human behavior. Can you please explain how this relationship impact food ulcer prevention in patients with diabetes?
Well, foot ulcers are a really complex disease, and they're caused by a very complex interaction of multiple factors. And that's, I think, what keeps me driven in this field. And I started studying as a human movement scientist, and within human movement sciences, you have sort of two different types of human movement scientists. Those focus more on the biomechanics, and those focus more on the behavioral aspects of the disease or the human body that you're studying. And I was always a little bit more on the behavioral side. And I was studying how people would use orthopedic footwear and what the behavioral aspects were that. And then I met Professor Sikobas, who was really on the biomechanical side of things. And we realized that to properly prevent foot ulcers, you really need both, because if you have an orthopedic shoe that is biomechanically absolutely perfect, but that's not used, doesn't make sense. And if you have a person whose behavior is doing everything to prevent the foot ulcer, but is using inadequate shoes, then you're still nowhere. And that's when we realized that if you want to prevent foot ulcers, biomechanics and behavior are really the two core businesses that you need on board. And from a traditional medical perspective, we've always been focusing in foot ulcer prevention on the neuropathy, on the peripheral artery disease, on the foot deformities. But all these variables, they are hard to modify. Once you have neuropathy, you can't undo it. If you have peripheral artery disease, well, yes, a vascular surgeon may be able to treat, but you only do that in very severe and advanced stages because surgery comes with a risk. And foot deformity, while there are some options to perform surgery on a foot deformity to really change it, which is an emerging field that's also really interesting, it's still not a very modifiable factor. Whereas biomechanics and behavior, those are the true modifiable factors in foot ulcer prevention, and hence our focus in our research on those two variables.
Yeah, fantastic. So that actually explains very well. And I'm very glad that you and Professor Sikobas met together and doing this amazing work. Otherwise, the global scientific community and patient would be actually missing a big piece that is actually now playing a bigger role for the advancement in food health. Well done.
I think you're way too kind, Sayed. But no, we definitely enjoy working together and try to do the best research we can to improve clinical practice here.
Great. So now we move on to our next discussion topic is real life and laboratory gait analysis.
Yes.
Your research incorporates both real life and laboratory gait analysis. What insights have these approaches provided in understanding food health challenges?
Well, there's a really benefit again in looking at the problem from different angles, and in this case, our angle comes from the gait lab where I work. So I work as a gait lab technician once a week at Amsterdam UMC, where we do the foot pressure mapping in people who are provided with new orthopedic footwear. But we also do the barefoot plantar pressure mapping in order to see, well, what could have caused this ulcer and what is the prognosis of this patient. And we have a variety of lab-based analysis that you can do immediately when a patient visits the clinic. That we can feedback to the doctor to inform the diagnosis and the treatment strategies, and it's really helpful to be able to do that in the lab straight away. And that's also how our scientific studies started. Obviously, in scientific studies, you want to control the environment, and in a gait lab, you can control many environments. You can study really in really high quality. What do the shoe like? How does this shoe work? What does it do? And so from that, we've learned a lot about how we can optimize footwear, for example. And one of the things also that you see now widely implemented in Australia is pressure mapping. So pressure mapping is something that Professor Sico Bus started doing in the gait lab. Let's measure the shoe before we give it to the patient. And from that, we learned that in the lab, you can already straight away see that the pressure in the shoe is too high. You need to change the shoe before you give it to the patient. And that's what we do in the gait lab now. We measure the pressure, and then when we're satisfied, then it goes to the patient. But that's where then the next step needs to be made is into the real life, because then the shoe goes with the patient into the real life. And then we realize that the same shoe in two different patients may have completely different effect, because if that patient takes 10,000 steps a day, or if the same patient only takes 1,000 steps a day, it's a completely different shoe. And what happens in the real life actually matters to what happens to the shoe and to the foot. Correct. And that's when we started to do real life gait analysis. So we have an activity monitoring device that we give to patients, and with that we not only count the number of steps, but we also count the quality of the gait, because shoes influence the quality of the gait, and some shoes actually to upload increase or decrease stability, and that you can see in the gait. But also you can see the variety of patterns during the day. Do people walk more steps in the morning than in the evening, or the other way around? Do people shuffle? What is the gait speed? Another question that in the lab we measure the gait speed, but we know that people in the lab, they walk faster than they walk in real life, because the lab is quite controlled, nothing's happening. And in the real life, we now see the differences appear. And it's quite a good correlation, actually. So people who walk faster in the lab also walk faster in real life. And what we're now trying to investigate is, how does that work? Are we seeing any patterns? Are we seeing ulcers more in people who walk faster or who walk slower? And what does it mean? And one of the surprising findings, actually, from our latest research is that we're now seeing emerging a group of patients who get a foot ulcer despite low pressures in the shoes. But those are the patients who walk much slower. And traditionally, we always thought that if you walk faster, or we know that if you walk faster, the pressure is higher. And that could be detrimental. But what we're now seeing is that we're having these fragile patients who walk so slow that the skin can't withstand any pressure anymore, and they break down. And so if you would look at this 10 years ago, you would say like, oh, these shoes are really good. Even if you would look at this 5 years ago, you would say like, shoe has really low pressures, all good. But now, if we look at it now, we go like, oh, wait, this person walks very slow, doesn't walk too many steps. This is a high-risk person that we need to sort of check really carefully, because something might be happening. And that's how we continuously try to marry what happens in the real life, what can we observe in the lab, and how do we benefit those two most from each other to give the best care and to provide the best knowledge to help prevent these foot ulcers.
Yeah. Good. What technology do you use for monitoring quality of gait in real life? Is it the same for the monitoring?
So we have the activity monitor. It's called the Move Monitor. It's made by a Dutch company, and it measures. So you wear it around your waist, and it measures the gait speed and it measures acceleration in a variety of axes. And based on that, you can then using all the algorithms that both the company as well as various researchers have made. So for this, we work, for example, with VU University in Amsterdam, who are our neighbors from Human Movement Sciences. And they created a lot of algorithms that, based on all the information from that, you can then quantify a variety of gait activity patterns that tell you more about the balance during gait, the stability, the medial lateral swing, and then all these factors that tell you something about, is this patient having a high quality, really good gait, or do we see a low quality gait? And we're now trying to find out in all those patterns, what then does that tell us about the quality of life of these patients, the ulcers that may appear. So many questions that we still haven't answered, but it's really interesting to sort of be able to dive into that.
Good. I'm really amazed to hear that you are about your findings. Actually, in my research also, when you looked at that, sometimes or in many occasions, the patient data shows fantastic, but the patients are re-ulcerating. So now I think it's answering a lot of those unanswered questions that there were something missing that we did not calculate in the laboratory. So I'm really keen to see what more comes out of this research. It's amazing, and I'm sure it will make a major shift in the treatment protocol and the way we look at pressure mapping data.
Yes, but before we get too high hopes, I still think that predicting a foot ulcer is really complicated,
Yes.
and it's such a puzzle where there are so many pieces, and we're now adding pieces. But don't think that we've solved the puzzle in a couple of years. But it's really about how do we lay these pieces of the puzzle that we can add, and how do we then use that in clinical decision making, and how do we feed that to the doctors and the podiatrist and the patients, so that everybody needs to contribute a little bit, and maybe we prevent some ulcers.
Now, good. That also correlates with your previous section that, okay, what we can control, we control that. So this might be some factors or parameters that we do not look at, but we will look at now, and we know that if we, for some individuals, if we control those parameters, might change the outcome a big time. So, and that leads to more personalization, which is again new topic. So that's really well done. I'm very glad that things are coming. It will help a big time for the clinician community and the people who are the receiver of the service. Great, well done. Now we are moving into our next question. Our next section is footwear optimization for prevention. We know footwear plays a vital role in foot health. What advancements have you seen in footwear optimization for the prevention of foot ulcers?
Well, I think we discussed some of them already. In 10 years ago, almost nobody was doing pressure mapping, and then we started to implement it, and now it's much more widely accessible. And I think that really is the biggest the biggest change in footwear optimization, because we're dealing with people with neuropathy who do not feel anything on their feet, and you put them in shoes, and we can't see what's happening in the shoes, and then you let them go home, and you hope that nothing happens, and you see them back when, well, yeah, something's broken. And so the big change now is that we at least can measure that. So that is the key breakthrough I think that we've had. But what are the next steps here in footwear optimization is that right now we're primarily looking at reducing peak pressure from the highest peak, and always using the 200 kilopascals as that holy grail, and try to get it lower. And now what we're trying to see is, okay, but there is more to tell. What about the gradient of the peak, or what about the moment in the stance phase that peak occurs? And does it matter if there are multiple peaks in one foot? And does it matter if that peak is on the hallux or on the first metatarsal head? And how does that all influence each other? And we right now have a PhD student who's looking at much more advanced statistical methods to be able to analyze that entire stance phase. And well, that's the first step. And now we need to translate that into clinical knowledge and shoe technician knowledge. And okay, if this means that, how can we then optimize the shoe? Because obviously for peak pressure, we've now learned a lot. And we are creating much better shoes, and that's something else we're seeing in our data also. If you compare to 10 years ago, when you would deliver a pair of shoes, peak pressures would be much higher. Right now, the standard is already much lower. So we've learned a lot from this.
Yes.
But we are still seeing foot ulcers occurring. So now we need to find out, okay, what are the factors here that play a role? Why are these foot ulcers occurring in these specific patients? And for that, we need much more information and then much more holistic view of all the pressure parameters that we're gathering. And then find out how do we then optimize the shoe, and where possible, then try to incorporate also the user-related outcomes. So can we then also create lighter shoes that are aesthetically more acceptable? Can we, based on that knowledge, define algorithms that we 3D print the shoes, so that we can not only do it in sort of countries where, like Australia, like the Netherlands, where you have high qualified podiatrists, but that we can do it everywhere. And I think that's the big next step in footwear optimization is, can we go from a sort of a more craft-based to a really automated system that is knowledge-driven, that can still be personalized to the individual patient, because for that you still need the contact with the patient. And how do we go there? How do we scale up everything? And that's where a lot of our research is actually focused on right now.
Okay, great. I'm really being amazed to see all the research work you have been engaged since a long time, and more innovation keeps coming. Now we will discuss our next topic, which is one of your focus also, is e-health solutions for disease detection and behavior change. So e-health, we know that becoming a crucial part of modern healthcare. Can you please tell us the e-health solutions you have introduced for detecting disease and encourage behavior change?
Yeah, I would love to sort of have these huge stories here about all the successful e-health solutions that I've introduced. But in fact, we're studying it. but getting them in daily clinical practice with the patients is a really huge step that we're working on. So one of the examples in Australia, we developed an app. It's called MyFootCare, where people can make foot selfies, and then it automatically detects the size of the ulcer, so that you can see it reduce. And it works really nice in theory and in the first trials, but then getting it with a population that is much older, often don't even have a mobile phone, are reliant on others. That's actually quite challenging. So yes, we're working hard on developing those. We're nowhere close to have that widely implemented. One of the things that I like most, and where I do see a future, is that one of the things we're doing in our trials right now is we put a sensor in the shoes, and that sensor that can read when the shoe is on or when the shoe is off. And based on that sensor, we get the information, what is the average hours a day that the shoe has been used. And rather than giving that simply back to the patient and with a message of guilt, like you need to wear your shoes more, what we do is we use motivational interviewing to then have a conversation about this. And that conversation can also be giving people compliments, but also sitting down and discussing it with them. And especially in this population, I think what we should always realize is people with foot disease, they are generally older, they're less tax heavy. And even though we're seeing emerging a new group of patients, and this is work from Peter Lazzarini in Australia, for example, where we're seeing that it's more the 40-year-old men that are now getting foot disease already. And yes, they have apps on their phone, but still, they may not have the health literacy to fully understand the app. So what I see as potentially successful e-health solutions are the solutions that are really emerged in a clinical system, and where the clinician and the patient can together discuss it, and then the patient can go home and feel supported by the e-health system, but go back to the clinician when needed. You're seeing some other examples here about smart insoles or smart thermometry, but all of them only seem to be really working when it's really integrated in clinical practice, when people are not getting overburdened, where people are not getting daily messages, but it really needs to be a combination of a patient, a clinician, and then an e-health solution that just sort of nudges the patient towards slightly better self-care, adequately supported by the clinician. And then, yes, we can prevent ulcers. And if we do so, we prevent huge costs, personal costs, financial costs down the line. But yeah, we have to be able and willing to invest in prevention in order to get there.
Okay, good. Do you see a benefit from support from family or carers or friends for adapting e-health for this population?
Oh, absolutely. I mean, it's any patient that you're treating in a personal health environment, and you have to find out what are the supporters of this specific patient. And for some of them, it's family, for others, it's friends, for some of them, it's the partner. But that also determines a lot of what's happening. And one of the things that I have not been able to really incorporate in my research, but what we are seeing, for example, is that people sometimes we see people caring for their partner, wife or husband, and then sort of dropping their own self-care because they're so busy caring for their partner, and then they do get a foot ulcer, and then sort of they and that's the moment that they can't juggle all their roles anymore. And that's when you have to realize you have to understand the environment the patient lives in, and if that's a tech-savvy environment, or there are people in that environment that are tech-savvy, then e-health could be a much better solution. But again, it's looking at the entire ecosystem around that patient, and that's why if I would be a podiatrist, I would like to have probably 10 different strategies. And e-health has 2 or 3 options in the end, but then there's a variety of others, so that I can pick and I can. And what we're using now is the word medical detective for especially the podiatrist in this case, but also for the podiatrist. If you comes in a patient, you have to be the medical detective and find out what is in this specific patient. Well, the factor that caused the ulcer, the factor that keeps the ulcer there, the factor that increases the risk, and then looking at all these different potential treatments that I have, which one do I pick at this moment? But to give clinicians a range of 10 different strategies, researchers need to probably investigate 20 or 100 different strategies in order to find out what are the winning strategies. And that's one of my frustrations in research right now in ulcer prevention. We are investigating almost nothing. There is almost no trials. Whereas in ulcer healing, we're investigating one dressing after another. And if I'm a wound care consultant, I can choose from 10 different dressing for one ulcer. And if I'm a podiatrist, want to prevent that ulcer from happening, I don't have all these strategies aligned. So that really is where we hopefully should get at some point together.
Correct. And on this point, I would like to have your opinion that in our clinical practice, we often see that the patient can be academically very, very literate, but from the health literacy point of view, may not be as high as their academic. So in that case, either family support, friends support, and extra support from the multidisciplinary team clinicians takes a long way. Do you see the same pattern in the Netherlands?
Yes, absolutely. It's those are different types of knowledge, and even people who have a high health literacy, when they experience periods of distress, and diabetes causes distress, and a diabetic foot causes even more distress, then that can block access to that knowledge in their own head. So right now we're working with La Trobe University on a project where we're developing a distress thermometer, so that you get a better insight into what is the level of distress that your patient is having right now, because that influences what they hear and how they listen to you. And the same thing, what we often think about education, for example, is that people with a higher level of education, so this is something that I often get back from peer reviewers, are the ones who will probably have higher adherence to footwear and higher adherence to self-care. What we're actually seeing, apart from the fact that the difference are non-statistically significant, is that those with lower education actually have higher adherence, and actually have higher adherence to self-care, higher adherence to wearing shoes. And why? I think it's because they listen better, and rather than sort of challenge everything and try to think for themselves, they sometimes just go like, okay, if this is what's told, let's do it. So again, all these preconceptions that you have, they're worthless. And the patient sitting in front of you may not fit any of the sort of little squares that you made. You have to find out with that specific patient, what is their health literacy? Do they understand what I'm saying? Are they willing to perform the self-care that I know that's good for them? But does it fit their life? Does it work for them? And there I think research can help you give the tools. And then as a clinician, it's about how do you apply all these tools to get to the best choice at that specific moment in time.
Okay, great. Thank you so much for your explanation. Now, this section next, we're going to discuss. I was actually waiting for a long time, and I was really curious to know a bit more from you and know what the novel things you have been doing. The future of foot health research. I'm aware that you are working on safe activity for the individuals with peripheral neuropathy and prevention of foot ulcers among this population.
Yep.
Your research on the safe physical activity for individuals with peripheral neuropathy and those at risk of ulceration and amputation is at the forefront of future health advancements. Can you please share more about this work?
Yeah, well, I think we've already really been working up to this in this podcast right now, because the future here is about the right patient, the right treatment for the right patient at the right time. And that's sort of the catchphrase from anything you hear in personalized medicine. And I definitely think that that's what's needed in foot ulcer prevention. And one of the key changes that we see that needs to happen is that if you focus on preventing a foot ulcer, you focus on something you should not be getting. And you can never celebrate something that you didn't get. You can never celebrate the goal that you didn't score. And that makes it really hard to keep up with. And so in psychology, this is called an avoidance goal. You try to avoid something. And well, the only thing you know today is that I've avoided it and it didn't happen to me today. I did not get a foot ulcer today, but that's not really worth celebrating. And so we had lots of discussions with patients, with clinicians, with researchers. What is probably a better goal? And that's how we ended up with safe physical activity. We know from many studies, also in this specific field, is that physical activity is good for you, good for all aspects of your health, mental health, quality of life, and physical health. And increasing physical activity has always benefits.
Correct.
But in people at high risk of foot ulceration, there is a huge risk that, or at least fear, that if you increase your physical activity and do it too quickly, that you actually get there where you didn't want to end, with that foot ulcer, or that you fall, because the more physically active you are, the more exposed you are to the fall risk. But you need to get there. You need to sort of slowly grow there. And that's what we then determined as safe physical activity. It's safe because it's working towards being physically active without getting a foot ulcer and without falling, to huge risk for people with diabetic peripheral neuropathy. But focus on the physical activity and focus on increasing the physical activity, because that is something that you can celebrate. You can celebrate that I am more physically active than I was a month ago. I feel healthier. I feel physically more fit. Correct. That is something that is actually a positive, and it's a goal that you can try to achieve. And that's where we think the future is. But so far it's been primarily theoretical discussions with everyone on the ground. And now it's about, okay, how are we now going to approach to work to that? How are we going to discuss this? And this is something we do incorporate at Amsterdam UMC already in our clinics. That's one of the beauties where, so Professor Sikko Bas and myself, our research team is really integrated in the clinic, where we have the rehab physicians, the endocrinologists, the infectious diseases, and everyone else. And we can really try and, what we think is helpful also actually implement in clinical practice. And yes, we try to sort of see, can we stimulate people to become physically more active? But there's a lot of work to be done to really integrate that, because our health system isn't really aligned to that. The current codes aren't aligned to that. But if anything in the future, I think we should be focusing on how do we get people both physically active and also free.
Okay. How do you envision it transforming treatment protocols and reshaping the approach to high-risk food management once this research outcome is in place?
Mm-hmm. Yeah, it's a tough one. As in, implementation is always hard, but it's about having as many strategies as possible. And I'm a researcher primarily, and so for me, it's about first of all making sure that we have the evidence that it works. And then secondly, well, get out there and make sure that the evidence reaches the people who need to implement it. Make sure that it ends up in the guidelines. I'm obviously heavily involved in the International Working Group on the Diabetic Food Guidelines. So and one of the things we're seeing is that if it ends up in those guidelines, yes, you have a much bigger chance that it will be implemented. But we also need the people on the ground to come up with the implementation strategies to tell us if it works or if it doesn't work. And we're now working with implementation scientists from VU University, for example, to create these implementation strategies. And yeah, in the end, it's like treating a foot ulcer. It's a team effort. We really need everyone in this field to work together, because there are so many patients out there and they deserve the best care today and they deserve even better care tomorrow. And that we can only really deliver if we all work together.
Okay, great. Thank you so much, Jaap, for explaining. And now I would like to ask you a question from your personal experience. As we know that you have a very strong connection with Australia, although you are currently working in the Netherlands, but you have done a lot in Australia. You lived here, you have been engaged in clinical research and helping with Australian diabetic food guidelines and helping educate the clinicians, working with the key researchers in Australia. And thank you for that again. And on this slide, given your expertise and extensive clinical and research experience in managing diabetic food complications in both Australia and in the Netherlands, what similarities and differences have you observed in patient behaviors across these two distinct climates?
I think the last word is probably already a huge first difference that I saw. Climate. The countries are completely different, and as you say, I've enjoyed Australia so much in my career, and a part of my soul probably still lives there. I'd like to go back, but it's just so far away. But no, the biggest thing I see in a challenge, I mean, there are different health systems, although there are also quite some similarities. But in the hot environment that Australia is, care really changes, especially with the foot. Anything you do with the foot has an effect on that. Secondly, with the distances being larger, what we're seeing, for example, in studies on physical activity, is that people in the climate around Brisbane take much fewer steps than patients in the Netherlands with more temperate climates. So Australians are probably more used to drive, to go to places with cars, to not walk that much, whereas in the Netherlands, the walking distances are much smaller. So that create definite differences. I think from our personal professions, footwear, the footwear branch in the Netherlands is bigger. We have better access to high quality orthopedic footwear than in the Australian system, although it is changing. Also from a casting perspective, so we have a lot of total contact cast, whereas in Australia I think there's a lot more walkers. But fundamentally, I think the differences are quite small. And again, it's really about being able to find the right treatment at the right time for that specific patient sitting in front of you, and the treatment principles and the fundamentals of the treatment, they're similar. They're similar in the same countries, and the behavioral aspects that you're seeing the same behavior in the same and in different patients. So fundamentally, I think we're pretty similar. And then also looking at living in both countries, I think the people also are quite similar. We have the same type of humor, and that's something that we also use in our clinics, and that you also use with your patients. So fundamentally, I think we're pretty similar, and everything we learn in both countries should be able to be implemented in the other countries, definitely.
Correct. Fantastic. Thank you so much again. Yeah. Now we are towards the end of this conversation. Now I have to reflect on today's discussion in a briefly, and I would like to hear from you also. So there has been a lot of new learning for me also from you from these wonderful conversations. So what is actually my take home from this conversation is that we control what we can control. We don't need to focus on what we cannot control. So biomechanics and patient behavior with motivation that we can control. We need to focus on that. And the other factor that we did not consider in the past in terms of patient care that can influence outcome towards positive, we need to focus on that. And safe physical activity, it is a crucial, and hopefully with more research outcome, we can find more parameters that we can take control and use as a good tools to motivate and educate the patient towards a better outcome. And yep, I will like to hear your thoughts as a closing remarks or the summarization of this conversation. And what would you like to say our clinical community and the most importantly, the people who we are dealing with and who actually we are having this conversation or we are doing all this work to help?
Well, I think I could not have summarized it better, Sayed, and it's really kind to sort of hear you say what I've been rambling on for this past half hour, which is very enjoyable. I think, well, for our patients, so we work a lot now with a patient group of patient representatives. And it's about, as a patient, I would say it's about find out what works for you, with whom, and what the factors are, and how do you sort of transfer that knowledge about yourself to the clinician. And for the clinician, it's about how do you develop that huge suite of options available, and how then do you make decisions based on actual knowledge about things that you've measured rather than sort of gut feelings. And that is the key, in my opinion, in personalized medicine, is if we measure what we really want to know and apply that in clinical practice, then we will be making better decisions that are making a better fit. And at the same time, as a clinician, talk with researchers, try to get everybody there. And the final is we really have to do this together. It's so complex. There are so many different factors at play in this tiny ulcer at the bottom end of the body called the foot. But in order to heal that, we may need up to the 25 different medical professionals involved and the patient at the heart work together, because that really is the only way we're going to solve this.
Very good. Thank you so much, Jaap, again. I want to express my heartfelt thanks to you for joining us today.
Thanks, Ayat. It's been very enjoyable.
To everyone watching, thank you for your time and support. Stay tuned for the updates on the 5th episode of Saeed on Air, where I will bring you another inspiring leader in the foot health domain. Until then, take care of your feet. And remember, healthy feet are the foundation of a healthy life. Thank you.